Well, everyone, welcome. Today, we're diving into a topic that sits at the heart, literally, of clinical medicine, cardiac arrhythmias. So, whether you work in the emergency department or on the wards, recognizing, understanding, and managing arrhythmias could be the difference between life and death. So, let's decode the rhythm of the art like we've never done before. So, let's talk about the mechanisms of cardiac arrhythmias. There are, let's say, two big ways. Two big ways that the heart can go rogue. First is the impulse initiation problems. Sometimes the problem starts at the starting line in the generation of the impulse, and that is what we call automaticity issues. Then some other times the problem is with the conduction of the initiated impulses. So something breaks along the track, for example, the reentry pathways. So you'll see these two mechanisms pop over and over in all arrhythmias, from atrial fibrillation to ventricular tachycardia. So every arrhythmia story starts with a misfire or a wrong turn. Now, automaticity. Automaticity is this art's self-starting engine. So cells like those in the sinoatrial node, they have the amazing ability to depolarize spontaneously during phase 4 of the action potential. So you think of the heart as setting its own alarm clock. It basically is very magical in the sense that it generates its own electricity, its own impulse. And you're looking at the sinoatrial node in the right atrium. So in automaticity, right? In automaticity, what you have is the heart's, it's the, like I said, it's the heart self-starting engine. So cells in the sinoatrial node, they have the amazing ability to depolarize spontaneously during phase 4 of the cardiac cycle of the action potential. The slope of phase 4 determines how fast these cells wake up. So what you have is the steeper the slope, the faster the heart rate. If the sinoatrial node fails, I always call the atrioventricular node the assistant. So the sinoatrial node is probably the consultant. The atrioventricular node is probably the senior registrar or the registrar. And if the sinoatrial node is messing up, the registrar steps in. And in this case, the registrar is your atrioventricular node. And if the atrioventricular node fails, say the registrars go on strike or are not available, who will step in? The SHOs, and in which case the Purkinje fibers. So apologies for the for the comparisons, but this is probably a way that it will stick in. So the Purkinje fibers can step in, and that's where you have your escape rhythms come in. The thing is, the junctional and ventricular escape rhythm, they often appear after the sinoatrial node suppression. So after you've given a beta blocker or in heart block, what you have is escape rhythms. So the slope of phase 4 determines how fast these cells wake up. And if the sinoatrial node is suppressed, the atrioventricular node or the Purkinje fiber step in, and that's where you get your escape rhythms from. And they come in when something has happened to the sinoatrial node. Beta blockers, like I said, can suppress your sinoatrial node. A diseased right atrium or can suppress your sinoatrial node, and heart blocks, like we did mention, something in the conduction can suppress the sinoatrial node. So after the polarizations and triggered automaticity, so what we mean here is sometimes the cardiac cells get overexcited and they fire off an extra beat before or after they're supposed to. So, and that's what we call after the polarizations. We have early after the polarizations, and then we have delayed and after the polarizations. That's what we call the EADs, early after the polarizations. The DADs, that's DADs, delayed after the polarizations. Now, early after the polarizations occur during phase 2 or 3, often during QT prolongation, while your delayed after the polarizations occur after full repolarization, that's phase 4, often due to calcium overload. Think about the digoxin toxicity here. So, after the polarizations can lead to triggered activity and ectopic beats that can spark a full-blown arrhythmia, just like to saddle point. Now, for the king of arrhythmia mechanisms, that's what we call re-entry. This is where an electrical signal loops around and reactivates tissue that should be resting. It's like someone is sneaking in the wrong way on a one-way roundabout and spinning endlessly. I think that explains it really. You're supposed to turn off at the roundabout, branch off maybe to the first and second exit, but instead, you're spinning around, coming back to the same junction over and over again. And it's chaotic, it's rapid, it's often dangerous. The most clinically significant arrhythmias are caused by this, where you have your atrioventricular nodal reentry tachycardia and you have your atrial flutter. Also, your ventricular tachycardia is implicated here. Now, what are the requirements for developing the re-entrance tachycardias? For re-entry to happen, three conditions must be met. First is a unidirectional block. So one part of the loop doesn't conduct forward. So let's picture the roundabout again. The car is moving. So one part, the car refuses to branch off because there's no the blockage out, there's no blockage in what maybe the first exit or second exit. So one part of the loop does not conduct forward. Two is heterogeneous properties. The two pathways must differ in speed or refractoriness, right? The circuit completeness, the tissue must connect in a loop. The roundabout must be a complete roundabout. So if one of the leg of the circuit recovers just in time for the returning impulse, the circus continues. Now, what are the requirements again? Let's add as well that the conducting pathway must be slow enough for the blocked side to recover. So what we mean here is that the conducting pathway must be slow enough to repolarize the resting tissue. And also the retrograde conduction must also be slow. If it's too fast, the part is still refractory and the loop dies. So the conduction has to be slow enough for it to be retrograde. And so, yes, arrhythmias love slow lanes. What an irony. Even though they are beating abnormally, irregularly, they like slow lanes. So here is a schematic to determine, to explain what we mean. As you can see, in the reentrant cycle, we've looked at a loop, a kind of closed loop. We looked at the situation whereby the reentrant circuit is there's a block, right? And the reentrant circuit is going, and we're looking at reentrant circuit initiation of entry and sustained entry. And so what this just means is that, imagine this wave moving through the heart and circling back because one pathway was temporarily blocked. So it just sets up a self-sustaining loop. And this is the electrophysiological basis of atrioventricular node reentrant tachycardia, Wolff-Parkin-White syndrome, and more. In practice, we break this loop with vagal maneuvers, adenosine, or ablation. And by self-sustaining loop, as you can see, the loop keeps on going on by itself and by itself. If there's enough time for any part of this loop, for example, to depolarize, by the time the loop returns, it repolarizes that cardiac tissue. And how do we treat? Management depends on the rhythm and the patient stability. That's one big thing with arrhythmias. Your treatment would definitely, one of the big things that determine your management of arrhythmias is the patient. How are they doing? Are they hemodynamically stable? And so our toolkit is we can use drugs, we can use ablation to zap the faulty pathway. We can use pacemakers to take over the pacing duties. We can use defibrillators to reset chaotic rhythms. We can use ICDs, which are internal bodyguards against sudden death. So you don't need to memorize everything today. Just know that the approach is tailored and dynamic. Know that if the patient is unstable, you want to stabilize the rhythm. And you can either do that with medication or you can do that with defibrillators, right? For antiarrhythmic drug therapy, they are complex. Why? Because they affect multiple ion channels, and the channels behave differently in different regions of the heart and under different conditions. The drug action varies based on the channel structure, the disease state, the voltage and time dependence, and off-target effects. That's why, some drugs work beautifully in one patient and they work terribly in another patient. To make sense of all of this, we have the Vaughan Williams classification. And what does is that it breaks drugs down by their primary mechanism. So in class one drugs block sodium channels. They block they slow conduction, and that's where you have your flecainide, right? In class two, you have beta blockers. Beta blockers suppress adrenergic stimulation, as the name implies. In class three, they block potassium channels. So they block repolarization, and medications here are like amiodarone. Class four block calcium channels, especially atrioventricular node, and that's where you have your verapamil. So it's just easy to remember. Class one, two, three, four, just say sodium, beta blockers, potassium, calcium, MBKC. So sodium, beta blockers, potassium, calcium, NBKC, and that's how you have your Vaughan Williams classification of antiarrhythmic action. And also, know that class one medications, what did we say class one medications are again? They are sodium blockers, right? They are good for rhythm control, but they can also be pro-arrhythmic, right? Class two, they are first line in rate control in AF. And that's where you have, again, we've talked about NBKC. Class two is your beta blockers. Class three, they work for rhythm control, especially amiodarone. And in class four, the slow atrioventricular node, ideal for SVT. Again, what did you say your class four medications, what did you say they do? They block calcium channel. So NBKC, sodium beta K, potassium calcium. So class 4, they're ideal for SVTs, right? Remember, the system is imperfect. Some drugs will act in multiple classes, like amiodarone anyways. Now, let's talk about ablation. Ablation is a curative option. We identify the faulty circuit and then we zap it with radiofrequency energy or cryotherapy. It is great for AVNRT, accessory pathways like in Wolff Parkinson White, atrial flutter, and even in persistent AF. So you would find some patients that come to you with at start of the medical issue, they've had cardiac ablation for atrial fibrillation, and the success rates can be high, even as high as above 95% for AVNRT. So the closing, what I want you to take home with this is, it may sound a bit complicated for some people, but just if you remember nothing else, just remember this: arrhythmias can be from the start of bad impulses or bad circuits. So basically, something wrong with the initiation or something wrong with the conduction of good impulses. And so think of bad generation, bad initiation, or a blockage or something wrong with the conduction. So you have to know the mechanism to understand the treatment. So you think about the electrophysiology, not just ECGs. And this knowledge will sharpen your ECG reading, your clinical thinking, and your confidence on the words, because yeah, you're thinking, oh, if this is a block, if this is an atrioventricular block, how do I treat? If my PR is prolonged, or if I'm having, maybe first degree or second degree or third degree block, what does this mean for this person? Not just for the heart tracing, what's going on in the heart, and why am I offering this medication? If you're having arrhythmias and it's an SVT or an AVNRT, you're thinking, what is going on in this person's heart? Why is it showing up this way? And why am I giving this medication? So thanks for tuning in. Let's make the heart reading one of the most thrilling parts of your clinical practice. See you in the next one.